Welcome back, everyone. Today we are diving into the palm of the hand, specifically a condition that looks like a nerve injury but is actually a fascia problem. Dr. Sarah, are you ready to talk about the Viking disease?
I am. We're discussing Dupuytren's contracture of the Palmar Aponeurosis. For those following along in the textbooks, this is a localized thickening and shortening of that triangular band of deep fascia in the center of the palm.
I love this topic because it's so visual. Imagine your palmar aponeurosis is like a high-quality camping tent. Normally, the floor of the tent, the aponeurosis, is flat and provides a nice firm surface for your skin to grip onto. But in Dupuytren's, it's like someone started shrinking the fabric of that floor. It gets tight, it bunches up, and it starts pulling on the guy wires, the fingers.
That's a great analogy, Dr. Khan. To be precise for the boards, it's a fibroproliferative disorder. We see nodules and cords forming within the fascia. And here is a high-yield fact for your exams. It most commonly starts at the root of the ring finger and the little finger. That's digits 4 and 5.
Exactly. So why does this matter clinically? Why should a student care if a patient has a slightly tight palm? Well, if you can't flatten your hand, your life changes. Imagine trying to wash your face and poking yourself in the eye, or trying to put on a pair of gloves, or even just reaching into your pocket for your keys. You can't. The hand becomes a hook.
And it's a permanent hook. The contracture draws the fingers into a flex state at the metacarpophalangeal, or MCP joint, and the proximal interphalangeal, or PIP joint. But Dr. Khan, notice something about the distal joints?
Oh, that's a classic clinical pearl. The distal interphalangeal, the DIP joints, are usually spared. In fact, they might even be hyperextended because the patient is trying to compensate for the flexion closer to the palm. If you see a patient with a bent finger, but the very tip is straight or pointing up, your Dupuytren alarm should be ringing.
Precisely. Now, let's talk demographics. If a question stem describes an older male of Northern European descent, you should immediately have Dupuytren on your differential. It's also frequently associated with certain systemic conditions. Dr. Khan, what's on your list?
The big ones are diabetes, smoking, and alcohol use. I've seen this so many times in my older patients who have had type 2 diabetes for decades. It's like the high sugar environment makes those fibroblasts in the fascia go into overdrive. In fact, many people call their primary care doctor of choice because they notice they can't shake hands properly at church or at a meeting.
That handshake is a huge clinical clue. Another one to remember for the exams is the tabletop test. You ask the patient to place their hand flat on a table. If they can't get the palm and fingers to touch the surface simultaneously, that's a positive sign. It indicates that the contracture is advanced enough that surgical or medical intervention might be necessary.
So why does this matter clinically when it comes to treatment? We aren't just stretching this out, right? You can't just yoga your way out of Dupuytren's.
Exactly. Physical therapy alone is rarely enough once those thick cords have formed. Traditionally, the treatment was a fasciectomy, surgically removing the diseased tissue. But recently, we've moved toward less invasive options, like injecting an enzyme called collagenase directly into the cords to melt them, followed by a manipulation to break the cord.
It's like using a chemical scissors instead of a metal one. But students, be careful. Don't confuse this with a nerve palsy. If it's an ulnar nerve issue, you'll have sensory loss and muscle wasting. In Dupuytren's, the muscles are fine, the nerves are fine. It's just the envelope of the palm that has shrunk.
Let's summarize the high yield points for the boards. 1, it's a thickening of the palmar aponeurosis, not a muscle or nerve problem. 2, it involves the 4th and 5th digits. 3, look for the tabletop test in the clinical vignette. 4, associated with diabetes, alcohol, and Northern European heritage.
And the final clinical takeaway, look for the nodules. Before the fingers curl, the patient will often feel a hard P in their palm. Catching it early can save a lot of function later. Thanks for the precision, Dr. Sarah.
Always a pleasure, Dr. Khan. See you all in the next session.